Thank you, everybody, for joining us for today's webinar, and we are glad to have you join us for Your Finances, Your Health, Making the Health Wealth Connection. My name is Carmen Shorter, and I am Senior Manager for Learning with the Field Engagement Team at CFED. And I just want to remind you that, yes, this webinar is being recorded. That tends to be our most common question. So, yes, we're recording today's conversation, and the recording and slides will be available within 1 week from today. To support that recording, all webinar attendees are muted, and at the same time, we invite you to share any questions or comments you might have at any point during today's conversation by simply typing your question or comment into the text box of your GoToWebinar control panel. If you experience any technical difficulties during today's webinar, we invite you to email us at gotomeeting@cfed.org. We're also inviting you to join us on social media. Please send your tweets, your comments, your hellos and happy moments to us by Twitter using hashtag HealthWealth, and you can chat at us or tweet at us at CFED and ANO Network. So we look forward to hearing from you on social media and getting this conversation out broader than just today's webinar. So a little bit about CFED. Our purpose here at CFED is to make it possible for millions across the country to achieve financial security and to contribute to the opportunity economy. And we do that through 3 different methods. We push to expand innovative practical solutions that empower low and moderate income individuals to build wealth and to keep wealth. We drive policy change at all levels of government, from local to state to federal. And we also support the efforts of community leaders just like yourselves across the country to advance economic opportunity for everyone. I want to introduce to you our speakers. We're really excited for today's conversation. We're being joined by Kate Griffin, who's Vice President of Programs here at CFED, and Kate will take on the role of moderating today's conversation. We'll also hear from Parker Cohen, Associate Director with the Savings and Financial Capability Team at CFED. We're really honored to be joined by Robert Vinci, Dr. Bob, who's Chief of Pediatrics at Boston Medical Center, and Joanna Ain, Senior Federal Policy Manager at CFED. So we, again, invite you to tweet at us at any time, chat at us in the chat box, and I'm going to turn things over to Kate to get us started.
Thank you so much, Carmen. And thank you to everyone who's joining us for today's conversation about your finances and your health. This is a topic that has received a lot of attention in our field as of late. Some of you will remember at last year's Assets Learning Conference, a very robust conversation on the topic, both in some workshops that we held as well as from the plenary stage when this was mentioned several times. You may have seen just last week the Asset Funders Network released an excellent brief titled The Health and Wealth Connection that explores how these things are inextricably linked and gives us all a very nice roadmap for how throughout the life cycle many of the asset building interventions are connected to health. So the reasons for this topic's relevance and saliency to the conversation, every year we learn more and more about how living in poverty and under financial stress has an outsized effect on physical and mental health. And everyone in this webinar knows the reverse, too, that the cost of your physical health or even one unexpected medical bill, what it can mean for your financial well-being. It's a topic that here at CFED we have been diving into more and more of late. So as we get started, first I want to make sure that we're clear on some terms that we'll throw around today. You'll hear us say both financial well-being and financial health. In a very technical sense, you can see that they have some slight nuances in their definitions. Today, we'll use those terms interchangeably to mean more or less your ability to get by and manage unexpected financial shocks today, and your ability to build financial resilience and set and meet goals in the future. Given the growth and interest in the topic, in this webinar, we want to talk about what specifically these connections mean for our field of asset builders, financial capability service providers, researchers, and policymakers. How does this look in practice? Where do we go from here to build deep partnerships with the health field that enhance both the financial well-being and health of low-income families? So our objectives today are threefold, and we want to bring this topic to the whole CFED community to achieve these objectives. First, we'll explore the linkages between health and between physical health and financial well-being. Before we go into the practical examples, we want to make sure we're all on the same page regarding how these topics are connected. And I'll be having a conversation with my colleague Parker Cohen about that. Next, we'll learn about an innovative model that's bridging health and wealth in one community. We're thrilled to be joined by Dr. Bob Vinci, Chief of Pediatrics at Boston Medical Center. Dr. Vinci was instrumental in creating the pioneering StreetCred program, which is a perfect illustration of what it looks like when the asset building and health fields are seamlessly integrated. StreetCred brings VITA services into pediatricians' waiting rooms and helps low-income families attain EITC and other benefits. We'll also hear from CFED's own Joanna Ain, who will discuss integrating financial capability services into community health centers and some of the policy implications we've been exploring of doing that. We'll then talk about what's next. What are the big opportunities that we see for moving this work forward? And finally, we'll close out with a robust discussion and opportunities for question and answer. So we hope to hear from you about how you are working at the nexus of health and wealth and what you're encountering in your communities. But before we dive in, we have a couple of poll questions to learn more about our audience. So first, we'd like to see who's joined us today and what field or what part of the field you come from. So we have a poll that we'll launch here that asks what part of the field do you work in? Are you an asset builder or financial capability provider? Are you in the public health or healthcare delivery part of the field? Are you some other type of social service provider? Are you in the research realm? We'd love to hear from you so we have a sense of who's joined us today. We'll be closing the poll just now. Great. What do we got? Wonderful. So we've got a fair mix of folks joining us. Certainly those who I hope are already Assets and Opportunity Network members within the asset building and financial capability field. Some folks from public health and healthcare, and we're so excited if this is your first time joining a CFED event. We're so excited to have you with us. Folks in other parts of social services, which play an integral part in what we're going to talk about today, as well as folks from other walks of life. We have one other sort of question that we have, which is just to understand people's experiences so far at the intersection of health and wealth. So are you currently working in the intersection of health and financial capability at this time? So we'll launch that poll. And we want to know whether, yes, you're doing it, whether you have plans to do it, whether you're just starting an exploration of that, or not having any plans. And definitely, we want to hear more about your answers to this in the comment box. It'll help us get a better sense of what has prompted you to join our conversation today. We'll be closing that poll in just a couple more seconds. All right, let's see what we got here. So it looks like a pretty big mix of folks who are already working in the field, who say that they're already, and a good mix of people who are just exploring this, and some folks who have some plans to launch soon. I really do encourage you all to tell us more about what you're interested in. And ideas that you have, and by the end of this conversation, we're going to talk about some ideas we have to engage further as you make your plans. So let's get started, and I said we would start this conversation by really getting on the same page about the connections between health and wealth and why they're considered so strong. So I'm going to invite my colleague Parker. So for those of you who have not yet met Parker Cohen, Parker's been working here at CFED for a number of years. He's in our Savings and Financial Capability team. He is an expert in the fields of matched savings in particular, and a little known fact about Parker is that he actually joined us from the healthcare field, where he spent a number of years working with community health centers. And we've really been leaning on Parker's knowledge of both the financial capability and the health fields as we've been exploring this at CFED. So Parker, I'd love for you to kind of take it away and tell us, what is the health-wealth connection? Can you shed some light on that?
Yeah, thank you, Kate, for that introduction. And before I dive into exactly what that connection is, I want to make sure that we're on the same page with some key health concepts. Some of you may already be familiar with these, but I want to make sure we're all starting from the same place. So, what factors contribute to our health? It's common to think of our health as primarily a result of genetics, healthcare, behavioral factors, such as diet or smoking or exercise. However, our health is a function of many different factors beyond these. About 50% of our health outcomes are attributable to social and environmental factors, as well as our physical environments. Research on the exact breakdown of these percentages varies a little bit, but what health experts do agree upon is that physical, economic, and social conditions in which we live have a large effect on our health. These conditions are known as social determinants of health, which can be defined as the conditions in which people are born, grow, live, work, and age, that affect a wide range of health, functioning, and quality of life outcomes and risks. Factors such as housing, education, workplace conditions, and socioeconomic status all contribute to our physical and mental health. So, to illustrate this a little bit, so safe and affordable housing, access to education, public safety, availability of healthy foods, environments free of life-threatening toxins, all of these can really significantly enhance population health outcomes. We all know, Kate mentioned this earlier, we all know from our own lives and work how health can impact your financial well-being, how an unexpected illness or medical expense can wreak havoc on your finances. And this relationship works in the reverse as well. Your financial well-being contributes in no small part to how healthy you are. So let's dive in a little bit into how our finances and health are connected. First off, the stress caused by living in poverty or financial hardship can lead to toxic stress, which has a whole host of effects, including reduced immune function, increased inflammation, and a greater likelihood of developing chronic disease. The impacts of this toxic stress and financial stress in general are very large in developing brains. Children raised in poverty are shown to have negative lifelong effects in areas such as cardiovascular health and executive function. Further, 30% of children in poverty are reported to have less than very good health, compared to just 7% of children who grow up at 400% of the poverty line. And, it's really no surprise that being under financial stress impacts your mental health. The Asset Funders Network new brief that Kate mentioned, the Health-Wealth Connection, highlights that 7% of no-wealth individuals reported psychological stress, compared to just 1.5% of high-wealth individuals. Financial stress also makes it more difficult to manage your health, from making and keeping doctor's appointments to following prescription regimens. According to CFED's Assets and Opportunities Scorecard, 14.3% of Americans did not see a doctor due to cost in 2014. This is a reflection of how your financial situation has a very real impact on your health care. Finally, having low wealth is associated with increased behavioral risk factors such as obesity and higher rates of behaviors linked to chronic disease such as smoking. All in all, the link is clear. Your financial health, and particularly your levels of financial stress, is strongly related to your physical, mental, and behavioral health. Put more succinctly, your wealth is your health. Low wealth individuals report having poor health at significantly higher rates than more affluent individuals. And these effects are more pronounced when taking race into account. White individuals surveyed reported lower levels of poor health than black individuals.
Parker, that was so clear and such a great, succinct summary of the data that links health and wealth. But you started really talking about earlier this concept of social determinants of health, which includes a number of factors. So I want to go back to that and push on you a little bit and tell us a little bit more about the relationship between financial well-being and these other social determinants of health.
Right, right. So your financial health impacts not only your physical health, but many of the other determinants that play a role in how healthy we are. So for example, the lower income you are, the less likely you are to have high educational attainment, live in adequate housing, or work in safe conditions. All of these outcomes lead to poor health consequences. So financial status is not only in and of itself a factor in your health, but it's also unique in that it influences so many other factors. And of course, all of these factors are intertwined, and the directions of these effects can be difficult to tease out. So it's a crucial reminder that we really need to be working across sectors to address different factors that impact our health. That's why it's so great to see so many folks on this webinar today from other social service fields and other fields that are interested in this topic, because targeted investments need to be made in all 5 of the key social determinant of health areas defined by Healthy People 2020. And these include the neighborhood and built environment, economic stability, health and healthcare, education, and social and community context. These investments range from savings programs for children and adults, for emergencies and retirement, to ensuring access to housing that is affordable and free of toxins such as lead and mold. Through a concerted cross-sector approach, we can really tackle these intertwined issues that affect population health.
Great, thank you so much. So that gives us a really good sort of theoretical underpinning for why we see these connections. But I think it's going to be helpful for us now to turn to Dr. Vinci and learn about what that means in practice. So Dr. Vinci, I'm sure that you've seen these linkages in your practice between health and well-being, but what we want to learn is sort of once you started seeing those things, what did you do about it? Tell us about the StreetCred program.
Yeah, thanks for inviting me to speak today. I'm really excited to talk about what we have built here at Boston Medical Center. I do want to say one thing, even though I'm speaking about StreetCred, as you will hear as the story unfolds, 2 of our pediatric residents, Mike Hole and Lucy Marcel, are really the individuals who brainstormed and created this. So StreetCred, as you will see on the next slide, is connected to what Kate and Parker was talking about before, and that's the overwhelming impact of financial challenges in healthcare. And if you look in terms of child poverty, 20% of the U.S. children, 16 million children, are growing up poor. And poverty and finances definitely impact healthcare. And we know that it leads to poor health. Children who live in poverty, there's a negative impact on school performance, and there's significant health expenditures and lost workplace productivity. So this is the battle that we face as pediatricians, and as healthcare providers, we need to build bridges with folks outside of medicine, because this really requires multidisciplinary engagement. Now, the good news is on this next slide, you will see there are hundreds of programs that provide benefits and services for low-income individuals. Challenge is trying to identify which of these programs are most impactful and which of these are easy to access for our families. And there's been a fair bit of work that's been done in this area to try and look at this. And on our next slide, you will see that a number of programs listed on the bottom axis. And basically, what this slide tries to demonstrate is which of these actually have an impact on poverty. And it's divided between rural and urban America, but the most noticeable thing that we want everybody to see is the incredible value of tax credits, and that it is, as studied, the benefits that will most likely impact poverty. And if you impact poverty, if you pull individuals and families out of poverty, you can improve their health, you can get them back to school, you can enhance the parents' ability to work. And it's not to say that Social Security, SNAP, which is food stamps, school lunch, housing subsidies are not important. We're trying to figure out with limited resources, where can we have the greatest impact? And this is the impact statement. This is really, knowing this is really the area that we want to delve into more deeply. How does the Earned Income Tax Credit work? As you'll see on the next slide, it really depends on your marital status and how many children you have. And if you were to just look at earnings of $30,000 on the x-axis there in terms of a family, you can see that as you move up the y-axis, the Earned Income Tax Credit that they are eligible for changes with their marital status and with the number of children that they have. And given that we know that this has such an enormous impact on child poverty, we really should think about how we can provide this level of service and what we can do to augment families receiving the Earned Income Tax Credit. So why do pediatricians care about the EITC? You know, I've been a pediatrician here for 37 years. Mike and Lucy are both pediatric residents. And they came and said, listen, there's lots that we can understand about the Earned Income Tax Credit, but more importantly, the Earned Income Tax Credit has been linked with improving infant health. And important indicators like birth weight and preventing premature birth have been shown to be benefited by families who receive the EITC. Families who receive the EITC, their kids tend to do better in school. And there's even a greater percentage of low-income families benefiting from the EITC because their young children are more likely to go to college. And it doesn't stop there. If you look on this next slide, you will see that there's increased work and earnings in the next generation. And there's been a lot of data. Actually, with the way things are happening in DC, this still has bipartisan support because it provides services to the poor. The Democrats love that, and it enhances the next generation of workers. So there's Republican support for this. But there's clearly a positive impact on increased work and earnings, and boosting employment and earnings of working age mothers and fathers with the EITC will boost their Social Security retirement benefits. Because even though we as pediatricians think so much about poverty in young kids, we want to be sensitive to what we're seeing here in America, which is an aging population. So this sounds perfect, right? The EITC makes a big difference in the lives of our families. Then what's the challenge? The challenge is depicted on the next slide. Sadly, that is a broken circle. And it's broken because 20% of eligible families do not receive the EITC. And that's what StreetCred is all about. So when Mike and Lucy decided to build StreetCred, it was to enable us to develop a program that would provide this service to our families. And they took it a step further. They actually decided that the way we should do this is to think about how to do this for free. Now, why pediatricians? Why not take advantage of some of the important community-based programs such as VITA, you know, the volunteer income tax assistance that the IRS has placed in many areas in the urban cities? Well, where do families go and who has access to kids? And on the next slide, you'll see that greater than 90% of kids have healthcare visits with their pediatricians. So it's a way for us as healthcare providers to say we need to think more broadly about the services we offer. And it isn't so much about why is this patient here for an ear infection, or tell me what's going on with this rash. It's really asking questions such as, tell me what's going on with your life and what has happened to you. And that's actually how StreetCred started. And I want to give Mike and Lucy the credit for really developing this. And the 2 buses, 1 train, and $400 was in reference to a patient that came to Mike as a pediatric intern. And in response to a question of what can I do to help you, this family said to him, would you help me with my taxes? And Mike knew about the VITA sites in Boston and referred the family to VITA. The patient took 2 buses and a train, got to the VITA site, and unfortunately it was closed. And so she came back, asked again, they tried again, wasn't successful, and the family ended up getting their taxes done, but paid $400 to one of the for-profit companies that provides tax services. It's actually interesting, if you look at the distribution of some of the for-profit tax services, many of them are in areas that are lower income and advertised to the poor. So Mike and Lucy took this on and came to me and said, we can do better than this. And that's what they did. They actually built StreetCred. And StreetCred is this remarkable organization, and as the tagline says, because you earned it, it's providing families both with an understanding of the earned income tax credit and allowing us to actually build a program that improves our ability to provide this. So we're really looking at building assets for vulnerable families. And the government has shown these are evidence-based anti-poverty programs that the government supports. But if 20% of eligible families are not getting them, and we know that families bring their kids in for health care, why not build this unique partnership? And we've been able to do that here at Boston Medical Center, which is a safety net hospital that serves very poor families. Those of you who don't know Boston, we live and serve the community that lives in and around Boston Medical Center. Over 40% of our patients live in poverty. 90% of our patients are insured by Medicaid. And if there are government programs and tax prep sites that exist in the community, why not build that in the hospital? So in partnership with the Boston Tax Help Coalition, Mike and Lucy and I built StreetCred. And StreetCred is that intersection of these circles. And it's the program that in our waiting room has families bring in the paperwork that's necessary for us to provide their tax returns. So they built this as interns. Last year, as second-year residents was year 1 of the program, and the results are remarkable. Last year, we returned over $400,000 to our families, doing about 200 tax returns. Of the 400,000, just under 20% was the earned income tax credit. And everything was done for free. Not a single patient was charged. Mike, Lucy, and I did some fundraising through the hospital because in order to partner with the Tax Help Coalition and be part of the VITA network, there are logistics and individuals and site coordinators who need to be part of the system. And what did our patients tell us? That was the other remarkable thing. So in addition to returning all of this money, half of our patients, our clients, paid someone to do their taxes last year. So an immigrant with a teenage son whose husband died suddenly, she paid a tax preparer hundreds of dollars to do her return. And like many of our families where English is not their primary language and they're looking at government tax forms, it's very hard to sort out. And her husband turned out never submitted her taxes. So StreetCred took on her case and recovered the thousands of dollars that she earned and did so for free. Sadly, 50% of our patients have never heard of the EITC, so we as physicians and you all as individuals who work in the space understand these benefit programs. But patients who are struggling with where they're living, how they're buying food, are probably not going to understand how they can access these services. And we had even one person tell us that knowing that the more you work, the more that you can get your EITC, the woman was stimulated to say, I'm working more. This is, in the long run, going to help me. And we need to think about it more than just tax returns. We really need to think about how do we develop and promote financial literacy education to our families. They deserve this. And that's why when Mike and Lucy were asked, what can we do to help you? And families said, help us with our taxes. We decided that we should do this. So I've alluded to the amount of money that we returned to families, and the entire cost for the first year was $19,000. The bulk of that was really for the staff and a little bit for supplies. And I have to be honest, it was a relatively easy sell for our philanthropic partners who believe in the mission of this institution, who helped us develop these resources so that we could provide this service to our patients for free. So if you look at our return on investment, that's greater than 20-to-1 return on investment, and something that we are really proud of because it is putting money back into the families who've earned it. It's helping to move families out of poverty. It's helping to improve the health outcomes of their children. And we think in the long run will help us to have more people working and help more families get out of poverty. So we've got community partners that are helping us. We've developed a community advisory board. I alluded to the Boston Tax Health Coalition, who've been incredibly important partners for us. And they've been really helpful in helping us think through how we can move this out. So not only do we offer it for our patients, we have many low-income families who work at Boston Medical Center, and so that we have begun to offer the service to our employees as well. Now, what's the best way of doing this? How can we as physicians partner with those who think about financial literacy and financial services? So we've built a research team, and we are now studying this. And what are the best practices? What's the best way to offer this? Should you connect this with a healthcare visit? Can we move this to other sites? And if so, how do we think about daytime hours, evening hours, weekends? And how do patients feel about disclosing their financial terms and their income statements and their benefits to the physicians who are caring for them? Well, we've had remarkable support from our families, and as we will talk about later, we are thinking of expanding this program because our patients have said this is incredibly valuable. And even the patients I alluded to who may not have used StreetCred last year, many of them said had they known about it, they would have used our services. The other thing we learned is, and it's we probably should have appreciated this, a very high percentage of families who know of the Earned Income Tax Credit file early because the money is so important to them and their survival. So making sure that we're up and running early in the tax year was important for us this year. and we've already doubled the amount of money that we have returned to families this tax season compared to last tax season. So on the next slide, here's what we're doing with StreetCred. So we're not making new wheels, we're not building more programs. We're just making programs that exist either work better or giving high-risk families access to them. We don't refer them out. The other thing we know about low-income families is life is very stressful, just like that family needed to take 3 modes of transportation to get to a VITA site. We don't want to refer them out to these sites. They trust healthcare sites. So let's build these programs at a healthcare facility. So it's a frequented space, it's a trusted space. StreetCred has impact when it matters most. And we're committed to this evidence-based intervention. And we think there's a message here for all of us nationally that we can deepen the impact that healthcare, American healthcare, can have as an institution that fights poverty and brings these evidence-based services to our families. So thanks very much for listening to this story. And on behalf of StreetCred and really on behalf of Mike and Lucy, Mike's been able to join me here, so if we have time for questions later, we can both help answer questions that anybody in the audience may have. So thank you very much.
Dr. Vinci, this is Kate again, and I hope we have the opportunity someday to invite you in person to a CFED event so that you can get the standing ovation I think many of us would like to give to you. For those of you who are longtime friends of CFED and interested in exploring this space, one of the things that I really want to highlight as we've been on this journey at CFED is that it is the pediatricians who are getting this, getting what it means for families, and thinking really practically about how it becomes a part of the way that they're doing their work as well. And so I think that pediatricians are the superheroes. And as a mother, that makes me feel really good. So we have lots of questions rolling in already, and really invite everyone to continue using the chat box and hitting us up on Twitter to keep asking those questions. Before we get to them, though, I do want to note that we have a couple of other examples to highlight. And we're joined here by Joanna Ain from our policy team. Joanna, I want to ask you first to tell us a little bit more about the examples that we've seen that involve community health centers, or CHCs. Tell us what those are, first of all, and why they make good partners as we think about these connections between health and financial well-being.
Great, sure thing. Thanks, Kate. First, to just highlight, Parker and I and a few others at CFED created the policy brief and released this recently, integrating financial capability services into community health centers. So I think you all received that. You can also Google it and find it on our website. So community health centers, CHCs, they're also known as FQHCs, or federally qualified health centers, and they're community-based organizations, and the formal mission of CHCs is to provide underserved populations with access to both primary and preventative health care services. So they serve similar clients to Boston Medical Center. They're funded in part by HRSA. Sorry for all the acronyms, it'll be over shortly. They're funded by HRSA, Health Resources and Services Administration, which is an agency of the U.S. Department of Health and Human Services, or HHS. Okay, no more acronyms. So in 2015, there was 1,375 health centers across the U.S. So to answer your second question, Kate, why do CHCs make good partners to connect health and financial well-being? There's a host of reasons. We go into detail in the brief, but I'm just going to go quickly through the top 5 for now. So first of all, there's overlap in population. Generally speaking, financial capability service providers and CHCs serve the same folks. So they serve low-income clients who a lot of times have very poor social determinants of health. For example, almost half of the patients who used CHCs in 2014 were enrolled in Medicaid, a quarter were uninsured. So the idea is really to meet the population where they already are, to let people go to one place and receive a range of services. Accessibility, CHCs are actually legislatively required to provide services in a way that makes it easier for people to access these centers. So a lot of times CHCs will have hours that are better for irregular, inflexible work schedules that low-income patients might have. Many CHCs are in neighborhoods with low-income populations so that they're easier for folks to get to. Trust is huge. Integrating these services into CHCs builds on existing relationships between staff and patients. You already have this infrastructure where staff is trained to discuss sensitive issues, so people feel comfortable, so it's really just building upon that trust. Scale, again, CHCs have a wide reach. Actually, 1 in every 12 U.S. residents use CHCs. That's more than 8% of the U.S. population. So this is a huge opportunity for financial capability services. And lastly, flexibility. CHCs can deliver financial capability services through models that really make sense for the particular communities they're serving. We heard from Dr. Vinci of connecting patients with VITA in waiting rooms. On the other hand, if you have a community with a really strong network of free tax prep providers, the CHC could also partner to host a tax prep site, or they can refer clients to a nearby site. So there's a lot of ways to provide these services.
That's great, Joanna. And it sounds like there's a lot of connections between the sort of themes that you're bringing up here and the exact reasons that Dr. Vinci talked about going into that work at Boston Medical. I want to remind folks, before I prod you a little bit more, Joanna, I just want to remind folks that we've talked a little bit about some other resources. Joanna is referring here to a brief that CFED published in the last couple of months. We've talked about an Asset Funders Network brief on health wealth. StreetCred has a white paper and a one-pager. All of these are available for download through the control box on GoToWebinar, so you don't even have to wait to get your hands on them. They're all accessible right here on the webinar platform that we're using. So Joanna, you set us up with the why, but let's go a little bit deeper and give us some examples of how we've seen this partnership between asset builders and financial capability service providers and community health centers.
Yeah, sure. So we've outlined a number of examples again in the brief, but here's a couple. One is helping folks enroll in public benefits programs. This can be something like SNAP or TANF or WIC. So really helping people improve their access to food and increasing their net income with these programs. Linking patients to credit counseling and debt management services. This can assist folks in creating plans to build credit scores and pay down debt. Facilitating one-on-one financial coaching sessions, and these can help individuals work towards personal financial goals they set themselves. There's just a lot of different ways to think about how to link services with CHCs. As I mentioned before, this can be done through referrals to other organizations, on-site, or this do-it-yourself model like we just heard about with Dr. Vinci, or through partnerships with providers. So one example in terms of the do-yourself model, one thought is to expand the role of health navigators who now help patients find health insurance on the marketplace. And I'll talk more about that later.
Great. Thank you so much for setting us up with that information. And again, all the white papers and things like that are available if you want to get into more details. Questions are rolling in. I'm so excited, and I know we want to get to the Q&A part, but I am taking moderator's prerogative. And I want to kind of bring in all three of our presenters, Dr. Vinci, Parker, and Joanna, to come back and really help us kind of look forward. Where do we go from here? We've got sort of the beginnings of some really innovative work, some really impactful work. We see the importance of this marriage between health and wealth. And so I guess what's next? How do we scale this work? So Dr. Vinci, I want to start with you and hear about what's next for StreetCred.
Yeah, Kate, thanks for letting us talk about what's next. you took the moderator's prerogative. I could take the speaker's prerogative. I'm actually going to hand the phone over to Mike Hole, who's sitting next to me, and Mike was one of the two co-founders of StreetCred, because he's going to walk us through what we're doing this year and what we see as next for StreetCred.
Yeah, thank you so much, Kate, and thank you so much to everyone that is listening to this. We're really excited and proud of this work, and so it's a real honor to be able to tell you about what we've been working on here in Boston. I think what our main efforts are now and thinking about going forward are expanding in two different ways. So the first is expanding to different sites around Boston. As Dr. Vinci mentioned, Boston Medical Center is the pinnacle of service to the underserved here in Boston, but there are a lot of other folks who have similar goals and missions in mind here in the city. So this particular tax season, we're not only operating at Boston Medical Center, we're operating at 3 other sites around the city. So we've partnered with the Martha Elliott Health Center, which is an affiliate of Boston Children's Hospital. We've partnered with South End Community Health Center, which is a freestanding clinic here in our organization, which is, you can see these organizations on the next slide. And we've partnered with a program called St. Mary's Center for Women and Children, which is an affiliate of the Boston Healthcare for the Homeless program. So we're really excited about bringing these services to these other sites. And as Dr. Vinci mentioned, we've already surpassed last year's goal ×2. And that's been in large part not only because we've increased efficiency at Boston Medical Center, but also because we have these services rolling out in other areas where low-income families with children are frequenting. And the other thing that we're thinking about is how do we expand other resources. So Joanna's mentioning of enrollment and other services was right on point. And as you can see on this slide that Dr. Vinci walked us through before, there are a lot of other services that are having positive impacts on children's outcomes as a result of reducing childhood poverty in this country. And we feel like we're very lucky to live in a country like the United States that understands and recognizes the struggles of families by creating these kinds of programs and funding these kinds of programs. And so, as you can imagine, because we do people's taxes, we collect a ton of data from families, not only on their demographics, but of course their financial information. And so one of the things we're thinking about doing is trying to streamline that tax data into applications for other types of government support. So as it stands currently, SNAP, which is formerly food stamps, as well as FAFSA, which is the application students fill out if they're going off to college for financial aid. Those two applications in particular have online forms that you can fill out. So you can imagine as we fill out folks' tax returns to get them these tax credits, we have that data on programs that we could theoretically then plug into other online applications. Our hope is that we could also talk with other types of offices like Joanna mentioned in terms of TANF and WIC, et cetera, that would also be able to offer applications online into which we could streamline some of our data that we're collecting from patients. So we're really excited about the idea of not only helping folks understand and get better access to these tax credits, but also help them address some of the other social determinants of health like food and housing insecurity, et cetera, by just coming to the doctor's visit and having these resources by the time they leave. And thank you so much again.
Great, thank you so much for sharing that, and thanks for joining us as well, Mike. We appreciate it. I'm going to pitch it back to Joanna as we look at the work with community health centers. And Joanna, you play a policy role at CFED. What are the policies that would help these partnerships flourish?
Great, thanks, Kate. So I'm going to actually take a step back and talk two things. First of all, with regards to the policy, we know there's a lot going on. We're in the midst of some very big changes in terms of healthcare policy. It's unclear what this is going to look like in the next few months. So that being said, we're going to talk about policy from a really high aspirational level and hope for the best for our future. The other thing I do want to do is talk a little bit about the barriers and then go into the policies. So barriers that come between CHCs and partnering with FinCap services. So those barriers, one is a lack of communication between CHCs or between the healthcare system and financial capability providers. A lot of times they're really two siloed groups. So a goal is to kind of increase that communication. Another barrier is a lack of funding in the field for this partnership. So we really want to think about how to improve that. And lastly, a lack of capacity with CHC staff who might not be familiar or actually even comfortable with financial topics. So thinking about training and thinking about, again, about partnerships. So diving deeper into those in terms of a lack of communication, thinking about how we can get out of those silos. Again, HRSA, which is the HHS agency, they can be more explicit. They can call out the strong connection between health and finances and encourage groups to really work together. They can list examples of qualifying services like benefit enrollment, financial coaching, help CHCs identify best services to meet their patient needs, a whole range of things. So really something to keep in mind about how best to strengthen that communication and that outreach. In terms of the lack of funding, thinking about how to improve funding, Congress can appropriate sufficient funding to support expanding these services, thinking about how to help CHCs test and implement and evaluate these services, perhaps thinking about how to provide innovation grants to CHCs, just a wide range of how can we expand these funding opportunities. And lastly, in terms of capacity, we've said before, first of all, training, thinking about how can we train these health navigators. Can HHS create a pilot training program to expand that role for health navigators so that not only are they helping patients find insurance on the marketplace, but they're also helping patients perhaps connect with financial capability services. In terms of partnerships, again, we've spoken a lot about VITA. So perhaps the Internal Revenue Service can provide information to VITA programs about partnering with CHCs and providing that tax assistance and even the health benefit enrollment piece. And lastly, HHS can think about providing guidance around a partnership between Assets for Independence grant recipients and CHCs. For those who don't know, AFI is an HHS-funded program that uses individual development accounts and connects folks with opportunities to save for home ownership, higher education, and small business. So thinking about how to, this is a great partnership, so thinking about how to increase these partnerships.
That's great. Thank you for giving that overview of kind of how we've been thinking about that. And I want to sort of plus one, if you will, this communications piece. I feel like at CFED over the last year, as we've been exploring this space, I know I personally feel like I've had to learn a whole new language as we've explored partnerships in the healthcare and public health fields. But Parker, you've been doing a lot of thinking about this too. And as we think about more broadly building connections and not just kind of the policy barriers, what's next in terms of building those connections between health and financial well-being?
Thank you, Kate. It's a great question. So at CFED, we see three big opportunity areas for furthering the work between financial capability and asset building fields and the public health field and health practitioners as well. So the first is expanding service delivery partnerships. So we've heard, on this webinar so much about these different partnerships between asset building practitioners and that have worked to really build fruitful partnerships with healthcare and financial services and vice versa. We heard about how StreetCred worked to build partnerships with the asset building community. And so this work is inspiring new projects nationally, and people are really getting excited about models like StreetCred and working with community health centers. And so we really want to work with our field, health practitioners, and the public health community to nurture these partnerships and also develop new ones, identify what's really working well, and work to bring those to scale across the country. So the second opportunity is really around broadening our coalitions. So as many on this webinar know, over the last 15 or 20 years, we've seen asset building coalitions grow in number and size across the country. At the same time, health coalitions that explore the connections between community development, public health, housing, and healthcare delivery have really grown as well. And so we need to be a part of their coalitions, these health coalitions, and vice versa. They need to become a part of our coalitions. And And through that, we can help coordinate service delivery and policy at the local and regional levels. So for example, these coalitions can assess local needs around financial health and physical and mental health, along with other deterministic factors that impact the health of the community. They can coordinate service delivery partnerships at the local and regional level, develop new funding strategies that can make those partnerships more viable. They can advocate for policies that would enable further collaborations between these sectors that all contribute to our health. And finally, this one's a little bit bigger and longer term in vision, but it's, how can we work with the health field to build better systems together? We see the future of healthcare including not just medical services, but a system that really takes into account all of the different factors that contribute to our well-being, so all those different social determinants. So how can we change how healthcare services are reimbursed to account for these factors and to pay for financial capability and asset building services? How can we work to reduce financial stress by bridging the racial wealth divide and making a more equitable tax code? Advances in these broader systems will really help us improve financial, physical, and mental health concurrently.
That's great. Way to end on a big vision. I like that. So that has been almost a full hour of a lot of really interesting and in-depth information. And thank you to all of you who have started to send in some questions. We're going to start getting to those here. Just a reminder, use the chat box. Go onto Twitter and use the hashtag HealthWealth and tweet at us at CFED and at ANO Network. I am going to hand the mic back over to Carmen Shorter, who is our resident webinar guru here, and she's got a number of questions to kick us off. Carmen?
Thank you, everyone, again, for just a really phenomenal conversation, not only here during the webinar, but in our chat box and on Twitter. So I'm looking at a sea of questions and comments, some of which we just won't be able to get to, but I suggest you get to Twitter yourselves and see what's been going on there. I will do my best to organize the questions that have come in, and some of them are specific to individual presenters, but I definitely want to invite everyone who's been a presenter today, and you, Kate, if you have something to say, to respond to some of these questions. So I think one of the perhaps easiest ones might be for you, Joanna. Is there a place where folks can find a map or a list of existing community health centers?
Yes, there is, but I think actually part of it.
Yeah, so HRSA's website, so that's HRSA, the Health Resources and Services Administration, does have a list of community health centers across the country. I don't have the URL off the top of my head, but it's something we could definitely send around to participants of the webinar in a follow-up email.
Excellent. Okay, so sounds like Google can be your friend if you're eager to know in the shorthand. But we are, again, recording today's conversation. We'll be sending out the slides, recording, and additional supplemental materials within a week from today. So you can keep your eyes open for that, and we'll include that link as well for the CHCs. So a lot of questions obviously have come in for StreetCred, and now that we've got both Bob and Mike, we'll try to lob you these questions. No guarantee that you'll be able to answer all of them today, but let's give it a try. So one of the questions is probably just a celebration of the work you're doing. The question was, how do we get StreetCred to hospitals nationwide? So not a small question there, but any suggestions for how this model can actually be expanded to other interested healthcare organizations?
Yeah, really good question. This is something that is probably our biggest challenge. Mike and Lucy and I are basically making contacts with individuals we know. There are some institutions that are doing some work in the financial literacy space, and so we're going to try and target partner institutions that we know serve a similar underserved population, such as Boston Medical Center, but a lot of it's going to be done word of mouth and connecting. We have published a paper on StreetCred that is one of the documents that Kate referred to before, and we're also looking to
publish a paper that actually analyzes the first-year results. We hope that that will open the door. And we've made contact with organizations such as the American Academy of Pediatrics. We're hoping VITA and their network will publicize this. So to the degree that all of you are listening, work in areas or have institutions that you think might partner with us, you can email Mike, Lucy, and I, and we would be happy to do the follow-up.
And we'll tweet that email address out while we're having today's conversation for folks who want to respond to that. And we can also put that in the chat box for those of you who are on the live webinar with us. So, Bob, Mike, can you envision a time where doctors routinely ask medical and financial questions, or any other healthcare practitioner? Is that possible in the near or short future?
Yeah, and I actually think it's happening already to a certain degree. One of the reasons why I chose to train at Boston Medical Center was because of its focus on service to the underserved. So we actually have a system here that doctors use when seeing patients in the clinical setting that goes through a lot of the resource insecurities that they might be facing. So we ask them questions about whether or not they have enough food for the evening, whether or not they have a safe place to stay that night. And what we're trying to do now is to ask them questions more pertinent to their financial well-being. So have they ever heard of the EITC? Do they make less than the $54,000 a year that would qualify them for some of these credits? And if so, have they ever got their taxes done for free? And what we're finding is that over and over, folks are more and more willing to share this kind of information with the trusted providers that we have in some of these clinics serving the underserved.
It sounds like the question might actually be for those who are working in healthcare. Can folks in healthcare envision themselves asking these questions or building the trust with the communities that they serve so that those kinds of conversations can happen between the medical provider and the underserved populations that they're tending to? So how did you all actually start promoting StreetCred services to your healthcare patients? Did you use community health workers? Were you using your own physicians and nursing staff to make that first connection?
We did a combination of all of the above. So actually in our first year, our main way of reaching patients was calling them by phone, which, as you can imagine, in a hospital as big as Boston Medical Center and a clinic that sees as many patients as we do, was quite the burden. So we set up these war rooms, if you will, where we would have several folks in the room making phone calls to patients, and we would say things like, we know you have an appointment with Dr. Vinci coming up on Wednesday. If you'll bring XYZ documents with you, we might be able to help get your taxes done, get you these credits that are known to have some benefits to your kids. This year, as we realized that that was such a burdensome process to call that many folks, we've partnered with the hospital's outgoing appointment reminder systems. So people who come to Boston Medical Center get an appointment reminder in the mail or by email, for example, and we've been able to attach, especially in the months upcoming to tax season, a reminder about our services at BMC. And we've seen a huge spike in folks understanding and wanting to use our service as a result of some of these things. We also, of course, have tear-off pads in the provider's room, so while the doctor is ending the visit, they can hand them this little referral pad that tells them about what documents to bring to their next follow-up and what number to call to schedule an appointment and so forth. So we've learned as we go along, and that's part of the reason why we have this innovation lab, if you will, at BMC, where we can try out these new services and try out new ways to reach folks and use our community advisory board made up of folks who are from the communities we're serving to ask them about what the most sensitive ways to contact them are, what the most effective way to influence them about the benefit of these tax credits, for example, for their children. So we're experimenting as we go along, and it's been a fun and certainly a process that we've learned a lot from.
And I'm gonna dig a little deeper then into how your program has decided some of the internal workings of your integration. So we heard both from Twitter and in the webinar chat box a few questions about HIPAA. And given that we also have VITA providers who are part of our Taxpayer Opportunity Network who are on this call, let's start with HIPAA. How did StreetCred manage the HIPAA rules around services? Were you doing these things in-house? Did you use third-party providers to help manage your privacy HIPAA requirements?
Yeah, that's a, this is Bob again, that's a very important question. And to tell everybody truthfully, when the lawyers heard that we were going to offer tax services to our patients, they called me and said, "What are you guys doing?" I said, "We're going to offer tax services." And they said, "No, you're not." And actually, you know what made a difference for all of you folks from VITA? The fact that we partnered with VITA and the fact that we did everything that was recognized by the IRS and the federal government, which is a secure system, allowed us to, both for HIPAA purposes, because everybody who is trained in HIPAA, as all of our physicians, and then we trained all of our volunteers the same way, we were able to meet the HIPAA requirements. And then for the logistics and the fact that we would be accessing our patients' financial statements, what made a difference to our lawyers is that we, with the help of the Boston Tax Help Coalition, whose partner is VITA, our partnership with them is what allowed everybody to sign off on this. So there was one or two edgy phone calls that I had to make, but honestly, because of the way VITA has set this up so securely, and we use their software and followed their requirements, so it allowed us to build StreetCred.
Excellent. And so for our VITA providers, it's a good reminder that the confidentiality rules from the IRS spec that help govern the integrity of your VITA work is also sort of case making then for healthcare providers who have to be responsive to HIPAA regulations. So might be worth exploring. And Parker, looks like you might have some feedback as well.
Yeah, well, I just have a follow-up question to that. So thinking about the data that you collect from VITA, and of course the health records you collect for your patients, do you store these data all in one place, or do you have to keep it separate? How merged are your electronic health records with this VITA work?
So another good question. So the two data systems are not merged, and so the tax records are in a secure area that is different from our electronic health record store. It is true that if a family needs access to their EHR during the times that we're doing their tax return, we can access that for them if they have a question or two, but the data sets are not merged. We did have to go to the Institutional Review Board in order to allow us to study the impact of StreetCred. And so as a third level for hospitals, at least as it pertains to the research aspects of our work, there's another mechanism to ensure that we're protecting the rights of our patients and that we're doing this in compliance with the federal laws and requirements around human studies research.
Thank you.
Thanks so much. We really appreciate your willingness to answer these questions. Again, the switchboards, as it were, are lighting up, and so I guess I'm showing my age with that. But so a couple of questions now about how to do some of the case making. If you were a VITA program or financial capability services provider, how might you approach medical providers to offer VITA or other supplemental financial capability services to your patients? Any suggestions on how to start that conversation or who to approach? And while you're thinking, I want to say thank you to J.C. Craig for asking that question, because it's one that a lot of us have been asking. And so, J.C., thank you again.
Yeah, no, I think it's, these are all great questions. I would start, so Kate made the point before, I realized that I am biased, that pediatricians are great people. So definitely you need a champion. And so I think access to healthcare sites can be a little bit complicated. I would look at the chief of pediatrics. I would look at the folks who run their ambulatory program. Many community health centers, which we're fortunate in Boston to have such a rich network of community health centers. And what Mike and Lucy have been doing, I'm going to put Mike on the phone, they're emailing COOs, they're emailing chiefs of peds, and you don't always make a great connection from day one, but what you want is connections, and if only 10% of these come to fruition, it's certainly 10% more sites than we have currently.
Yeah, and all I can say as being one of the residents is that having Bob as our primary mentor on this project has been invaluable because he's able to call up the lawyers, he's able to call up the HR department and help us cut some of this red tape. And so what we're learning as we've expanded to our other sites too is that who that contact person is makes a big difference. And so as you can imagine, as we have to, for example, onboard our volunteers with some of the compliance measures of the hospital, like getting them the appropriate vaccines or making sure that they're HIPAA compliant. There are certain folks who are tied into those processes that have been really helpful in streamlining those processes and making it a more efficient process for us. And then you can imagine there's folks in the hospital who aren't tied into that, who may be mostly clinically based in a clinic and may not actually have an idea of how the operations work behind the scenes. So being thoughtful about that is certainly something that's important, and I think especially for the folks on this webinar, we'd be happy to partner with you as you start to think about how you enter a certain healthcare site and help us share some of the pitfalls that we fell into at the very beginning and some of the ways that we've been able to streamline the process going forward.
Can I ask a follow-up? This is Kate. I want to jump in on this because I think when here at CFED, we've been doing a lot of work over the last few years as we think about some of these systems integrations. And the work that we try to do is uncover what the sort of most important motivation might be on the other side of the table and try to see what the data is that supports that. So we've done in this webinar a nice kind of walkthrough of the social determinants of health, of key government programs that are best at fighting poverty, the role of poverty in children's health. And you had some really great data about the low cost of this program and the return on investment. As you think, particularly Bob, thinking about your role as the chief of pediatrics at a large hospital, what's the business case for you? Which of those data points is the one that says, yes, I need to invest in this?
I think we made the business case in a few ways. First of all, so we presented this project after the lawyers said to us, you can't do this, and we walked through that. We presented the business case, and Mike and Lucy, in about 6 months from our philanthropic partners, raised about a little over $100,000. What made the difference was the tagline about this is money that our poor families have earned, that 1 in 5 are not getting, and that we, with minimal investment, at least minimal financial investment, Mike is being too modest. The work that he and Lucy have put into this has been fairly intense, and as residents who are already working a large number of hours, I think for the institution, what allowed me to make the business plan was, A, this is unique, and it will continue to put BMC on the map of building creative programs, but more importantly, at the individual level, it's a minimal financial investment for altering the lives of our families. And I think it's probably twofold. I think it's the general, we're helping families, but the specifics that investing $1, we're returning $20 to families who live in poverty. And I think that's how we pushed forward with this.
Excellent. So I know that we are getting really short on time and we have a number of questions coming in. So I'm going to try to narrow these down a little bit. So a couple of people are interested in the various professional roles that could help in this. And so do you see a role for social workers in making the case or helping provide the services for low-income clients at health centers?
Yeah, the short answer is yes, and that's based on our experiences already working with a lot of the social work teams in the clinics in which we've implemented the service so far. If you think about the work of a social worker, especially at a place like BMC, where, as Bob mentioned, a huge majority of our patients are on Medicaid and are likely struggling to make ends meet for various resources, they are only a few people in a huge sea of folks who are in need. And so not only are they good at their job, but they're also limited in their time. And as you can imagine, as social workers think about dealing with crises and interventions need to be happening immediately, like, for example, domestic violence or immediate homelessness, that limits their time to be able to think about some of these other types of resources that are beneficial to families, like getting their taxes done for free while they're waiting on their doctor running behind schedule like me. So we've definitely taken advantage of the idea that now, because social workers are working in-house in a lot of these hospitals and clinics, they can just refer down the hall to the StreetCred desk where we can take care of some of these other types of resources.
Excellent. And a question came in about cultural competency, and maybe social workers help play that role. How does StreetCred think about language and other potentially cultural barriers or opportunities to make the services more widely available to your full range of clients?
I think the biggest way we do that is by asking the folks that we're serving. So as Bob mentioned before, we've built this community advisory board, and it is made up of clients who've either taken advantage of our services in the past or who would be eligible for our services going forward. And we ask them questions exactly like that. Things like, is it okay that we have a phone interpreter in the room rather than having an in-person interpreter? Is the way that we're reaching out to you by mail not only effective, does it get into your mailbox, but is that an appropriate way, and is it in the right language? So I don't know that we have any magic answers, but we have questions that we can ask of folks who might have those answers for us, and that's been the huge benefit of being able to partner with members from the community as well. To put that in perspective as well, there are folks in at least Boston Medical Center called patient navigators, and those folks are able to help families connect with the various resources that exist in a city like Boston. And those navigators come from the community surrounding Boston Medical Center. So they are people that live and breathe the resources that they're often connecting the folks who are in need of them with too.
I'm hearing a lot of program minds turning their wheels, thinking about all the different ways that these innovations can happen. Now, I want to switch the conversation to evaluation and impact. A lot of people are trying to figure out, maybe you can help us think through this, how does StreetCred evaluate your impact? And even if it goes beyond EITC, is there an assessment of overall health? Are there any other parts of your evaluation that you might be able to share so people can hear what's possible and maybe ways to think about evaluation? Any particular milestones, for example?
A really, really good question. I wish Lucy was here too, because she's in the spearhead of our research team in a lot of ways. You know, in our first year, we were really trying to study whether or not this was a program that was feasible to achieve in a place like a healthcare setting, whether or not it was well received by not only the clients, but the physician and clinic staff partners as well. As you can imagine, we were worried that this might mess with the flow of the clinic, and we certainly didn't want to create more burdens for already overworked folks in the clinic setting. And so our first year focused a lot on understanding whether or not those kinds of things were in line. And fortunately, as Bob alluded to as well, we're going to publish some results hopefully soon about our positive outcomes. Going forward, I think the question is, as you alluded to as well, how do we figure out whether or not we're having the kinds of impacts that have been studied on the EITC in these smaller settings? And the truth is there haven't been randomized control trials to date on the earned income tax relief that we're aware of evaluating some of the health outcomes of kids. And so we talked about the links between higher birth weights for infants and lower infant mortality reduced maternal stress, improved K-12 school performance, higher graduation rates, etc. But we haven't been able to say, all right, we have a StreetCred intervention at 3 clinics here, and we don't have it at 3 clinics here. Let's look at those populations going forward and see whether or not we're having an impact that we tout. And I think not only for health impacts, we're thinking about this from a financial perspective too. As you can imagine, maybe not in Massachusetts, but in other states around the country that didn't pass, for example, the Medicaid expansion bill, we have higher rates of uninsurance around the country. And so let's say that we collect folks' tax data in one application, but we can plug it into a Medicaid application right there. And so now instead of the clinic eating the cost of taking care of that patient, they're now going to be reimbursed by Medicaid. So we're looking at not only how we can improve value-based care, especially if healthcare moves to a system that's reimbursing for those kinds of things, but also in the short term how we can save hospitals costs by streamlining these services in their clinics.
And just one last question, I think, before we have to move to close. And the question came in about funding. I know that we talked about your origin funds and how you got started on $19,000. And as you're thinking about your expansion, are there any thoughts you have about how this work can continue to get funded? And in particular, is it conceivable that at some point either Medicaid or Medicare might fund these kinds of services, or that, you know, at a community center or community health center like yours, that there might be some other sort of fund, like a community benefit program, to help pay for these services either in the community or at the hospital?
And the short answer, I think, is yes. That's something that we would aspire to and can imagine the kind of impact we could have with that sort of funding available to us. One of the things that we've done in the short term, and I think this will be even more readily able to be asked for if we can show some of these improvements and outcomes going forward, is that we've asked that our partner sites, the clinics in which we're operating, support a big portion of the salary for the site coordinators that are there. So that salary is a IRS mandated or a VITA mandated portion of the program, and so and that has been the big cost for us as well. The other reality in the equation is that hospitals have a community benefits requirement. So a lot of, even thinking about broader, and some corporations as well have a requirement to improve the health of their communities. And so we've been really, really lucky to be partnered very closely with the BMC Development Office, and they've been huge in helping us think about what types of resources we might be able to take advantage of, from fellowships and grants to more permanent corporate donors, to even grassroots fundraising in the communities nearby. So we've been lucky to partner with them, and certainly would welcome the thoughts of folks who are in the space even more often than we have been as of late to help us think about how we might be able to fund.
I like that you ended it with a soft lob back to the asset building field. That's perfect. And I want to thank again all of our speakers today who have joined us for this conversation. It's been just a really dynamic conversation. So I want to thank again Kate Griffin for serving as our moderator and helping facilitate this dialogue with Parker Cohen and Joanna Ain from CFED, and both Vinci and Mike Hull from the Baltimore Medical Center StreetCred program. Boston, sorry, did I say Baltimore? Maybe I'm projecting we want to expand out there. So a couple of notes. Again, at CFED, we do provide support for both the Asset Building and Taxpayer Opportunity Network field. So Assets Opportunity Network and Taxpayer Opportunity Network are two CFED learning communities and peer communities that you can join if you're not a member already to have this conversation, to learn more. And we're actually exploring the question of whether or not we want to create a curated space specifically to talk further about the health-wealth connection. So if you are at all interested in continuing this conversation, there's a couple ways you can do that. We ask that you stay on, and in just a few minutes we're going to launch a poll to ask you what your interests are and how you'd like to continue. We're going to invite you to stick with us on Twitter and keep the conversation going. And we also want to bring to your attention a few resources available to you. Again, during the conversation we shared that there are 4 resources you can download now from the GoToWebinar control panel. Those are still available to you. We also want to show you some opportunities coming up with the Asset Funders Network. Again, the brief that just came out that they produced, the Health and Wealth Connection Opportunities Across the Life course, is available for download now. And if you can't access that, we will be sharing it again after this webinar with the recording and slides. There are a number of regional roundtable discussions that they will be hosting across the United States. They just had their first in San Antonio, Texas. And across the next month and a half or so, you'll see that they have a number of continued conversations going on. If you can make it, please join or keep your eyes open for feedback from those conversations. And they also are hosting their AFN National Grantmakers Conference in May in Indianapolis. So if this is a space where you are interested in working as a researcher, as a funder, or you want to find out more about what funders need to know to get this work going, I recommend you check out their resources. So again, we invite you to stick on for just a little bit longer and complete the upcoming survey. It's really short, but your feedback is valuable. Let us know your suggestions for future learning events, either on this topic or any other topic that seems important to you as a asset provider or a service provider or a Taxpayer Opportunity Network member. And if you're not already a member, please join our network to stay informed and engaged. So with that, again, my name is Carmen Shorter. We're really glad that you joined us here for CFED's webinar on the Health Wealth Connection, and we will be talking with you again real soon.